bracing of the supraspinatus,
Okay.
supraspinatus and infraspinatus.
Yeah. So you have done the inspection. Move on.
Uh, so, after inspection on palpation, starting with temperature, tenderness, I will check for the tenderness of all the bony prominences
Okay. There is no tenderness
and
anywhere. Move on.
uh, then pulses and sensation. Then I will
This is sensation
check
done.
the
Next.
range of motion of the
Okay.
right shoulder,
Okay.
active, both active and passive.
Okay. So you have done the range of
If
motion.
they,
The patient is uh, struggling to do the abduction. What else?
okay. So then I will try to correct the abduction passively and note the abduction lag and extension lag.
Okay. You have done the passive movement as well. You're
Then I
so
will start with a special test on this patient. The
okay. Yeah.
special test,
What are the tests?
uh, so I will first of all I will check for test for impingement, which includes job test, a drop arm test, and Hawkins and cross arm.
Hawkin, what did you say? Hawkin?
Hawkins test for impingement.
Okay. So drop arm test is negative. Hawkin test is negative.
Okay.
How do you do Hawkins test? Do you know?
So by flexing the elbow at 90 degrees and
Mhm. Elbow.
shoulder abduction internally rotated at 90 and do the internal rotation of the shoulder.
Okay. Okay. This is how you perform Hawkins test. Okay. Any other test that you would like to do in this patient?
Uh, uh, the empty can sign job test for suppressed kinetic
Jobs. Okay.
and the plus test for subscapular and horn blows test for suppression.
Do you know?
In fact,
Okay. How do you do hornblower sign?
Triangle.
so by abducting and the 90 to ask the patient for externally rotate the shoulder
Extended rotate the shoulder. Okay. So, okay,
against the
let's go
shoulder.
to the, I think the time is up. Sorry. I will go to the feedback. Irfan, can you go to the first case, please? X-ray first. Okay. So, Salman, I think you need to be more fluent and be more confident. Okay. And you need to, uh, I think you need to just have a bit more grip on the schemes. Okay. So, you are struggling to describe the test at the moment, but with the rehearsal, inshallah, you will improve. Okay. So the thing is, when you see this C-gone fracture, when you see this kind of fracture, you said there is a chip fracture. There is nothing chip fracture. Okay. You can say avulsion fracture. Okay.
Okay.
First of all, these are the minor things they are looking for. They take these things into account. Okay. So if you are examining, uh, let's say you are examining final year student, you will pick up these things that the candidate is struggling to define, or the candidate, where is he, whether he is fluent or not, whether he is confident or not. So same thing. So when examiners are sitting in CPSP, they have lot of experience. They have examined thousands of candidates, so they can very quickly pick up which is candidate is more fluent and confident. Okay. So you need to sound confident. You are a consultant level. You are giving exam of a consultant level. Okay. They think you as a consultant, as a colleague. Okay, you are no more a resident, first year, second year resident, where you have a margin of error. Okay, so when you see this second fracture, just quickly jump onto the ACL. You know this is a ACL injury. You need to convey them that you know that this is a second, this is a ACL. Okay, and then in a knee is an ACL, and a knee is a very hot topic. It will come in any way. Either it will be a talks, either it will be a short case, or either it will be a long case. It will come for sure. So you must be very fluent and but just be very quick in the knee examination. There is no margin
Case
of
is for distinction, basically. Sorry to
yeah,
interrupt, Salman.
yeah. So when you see a knee examination, so just so you know the crux of the numbers is with the special test, not with the inspection and the other things. I know you need to mention these things, but be very quick. I will inspect the patient, look from the front, behind, back. You will basically look for the wasting and scar mark. Okay. And the popliteal fluence, you can say that like you mentioned. Then you will see the walk of the patient, how the patient is walking. Then quickly you will lie down the patient and you will start your scheme. Okay. You mentioned
Okay.
patella test first rather than going to the ACL first. So patella comes at the end of the scheme in this ACL. ACL takes the priority and preference. So you will start with the Lachman. First of all, you will do the Lachman test. Then you will do the anterior draw, posterior draw. There are so many tests. Okay. But you need to stick to some of the simple tests that are easy and quicker to perform. And that will give you a clue that this patient has an ACL injury. Then you mentioned
Okay.
McMurray at the very end. You need to root out the meniscal injury, which is very common with the ACL injury. Okay. Valgus various stress tests are important, but before them, you need to do the McMurray test. Okay. Don't forget the McMurray test. Then they can ask you about the uh, pivot shift test. Then for the posterior external rotation leg, and not the external rotation, I forgot the name, where you basically make the patient prone and do the test for the ACL. Okay. So in the portals, you should know when I was going to ask you about the choice of
Graph.
graphs that you can use. What are their strengths and what are the implication of each graph? Okay. And portals, you said entero superior, enteromedial. I forgot, what did you say? You didn't describe it very well. Okay. So there
Yes.
is enteromedial and enterolateral portal, that these two portals are made. The thing they are looking for, how to make your tunnels. You should mention for femoral tunnel, it's 11 or 1 o'clock, depending on right or left knee. Yeah. And in which position you are going to make a femoral tunnel. You make femoral tunnel in flexion, then you make a
Right.
tibial tunnel, then you pass the graft, then you put the screws. In what position you put the screws? These are the things they are looking for in the
Okay.
ACL. Okay. So in the second case, it was a shoulder examination. So I would say your fluency a little bit better than the knee case, but still you need to be more fluent in the. I think you were surprised by looking at the MRI. I don't know whether you have seen MRIs or you have. I mean, you have learned to read how to read the MRI. So whenever you see MRI, just say this is a T2 weighted images, corneal T2 weighted corneal imaging, corneal sagittal or whatever image it is, and just go to the finding that you can see there is a. And whenever you in MRI, if you can't say anything, like in ACL, you were saying it is a partial tear, full tear. Just say there is a hyper intense, hyper. What is it called? There is a
Hyperintensity.
high intensity
Mm,
signal in this region.
High intensity.
Mm. High
Okay.
intensity signal. So this will say that there is some problem with that structure. Okay. We are not the radiologists. They are not assessing your radiological knowledge. Okay. But you need to pick up the things. Okay. And in the in the shoulder examination, so you didn't come to the most important bit. You need to check all the rotator cuff muscles. Okay. Supraspinatus, infraspinatus, you must know at least one test for each. Okay.
Okay.
So please revise your schemes and practice them so that you are doing it on your spinal reflexes. वहां पे सोचने का कोई टाइम नहीं है, वहां पे सिर्फ आप वही परफॉर्म करोगे जो आपके स्पाइनल रिफ्लेक्सेस है ना, वही चलेंगे बस आपके. ठीक है.
Thank you, Salman. I think so far candidates are struggling with describing MRI. Salman has given a valuable comment that just relax, take a deep breath, and say this is a T2 weighted image. When you see these white shadows, describe which view is this. This is a T2. I mean, if this was T2 coronal image, the most obvious finding are there is discontinuity and high intensity signal at the attachment of supraspinatus. There is some free fluid under the subacromial space. My impression is there is a subacromial impingement with the supraspinatus tear. This is a T2-weighted image with the axial view, the most obvious finding. I put this MRI because there is subscapularis tear along with bicep subluxation that is characteristic for this. All right. So please learn how to describe the MRI. So is Jahandad here? I think he was struggling to join. Jahandad, are you here? Otherwise, we will go with the Adnan Makbul first. All right. So I think Heather is here, candidate, and he's still on duty. But I'm very thankful to Heather that he came. Heather, if you are comfortable taking these two cases before going, as he has to go ahead for the morning trauma meeting as well. Heather, are you comfortable to take these two cases?
Yeah. I can start, and yeah,
All
I'll
right.
let you
Thank
know
you
if
so
there
much,
is
Heather.
anything.
So Jahandad, are you here or should we go with Adnan Makbul? Jahandad, are you here? So I'll go with Adnan Makbul. So Adnan, can you see this?
Yes, sir. Assalamu alaikum.
Walaikum salam. So Heather will take you. Bye.
Yeah.
It's
Hi,
close.
Adnan. Hello.
Hello, sir.
Yeah, I'm Heather here.
Thank
So
you.
this 75-year-old patient presented in A&E. So what can you see?
Sir, I can see the lateral view of X-ray of the knee with the implant in situ of the total knee with the periprosthetic fracture in the femoral part. Sir, there is
Okay.
seeing no loosening. Cement interface is not appreciable in this view. So I can want another view with the AP view and full length X-ray of the femur and knee.
Okay. That's all the views. So how will you proceed further? Like, what else will you like to do? The
Sir,
accident
on the
and
basis of
emergency.
yes, sir. On the basis of the emergency management, I will start with the ATLS protocol, and then I will rule out with the after ruling out the ATLS protocol, then I will proceed with the neurovascular examination. And after ruling out this, I have to stabilize the fracture with the long back slab, above knee back slab. And then I have to rule out any implant loosening, and will plan for the further management after taking the fitnesses of the patients and counseling the patient and ruling out.
How will you rule out the loosening of the implant?
Sir, with on the both of the X-rays, implant losing can be appreciated on the basis of septic and aseptic loosening. If first of all, hematological workup should be done to rule out any septic loosening with the CBC, ESR, and CRP, and aseptic loosening can be ruled out with the bone cement interface. Lucency is present
What
in.
investigation will you
Yes, sir.
order to? What investigation will you use to help you with the loosening?
Sir,
And
infective pathology should be ruled out with the CBC, ESR, and CRP. And
other than the blood test?
yes, sir. Other than the blood, sir.
Okay.
Sir, alpha defensive levels on the research.
Alpha defense is to look for infection. Okay,
Yes, sir.
so how will you classify this? And do you have any classification system for periprosthetic fractures around the knee?
Yes, sir. इसमें sir classification, sir. Vancouver classification है with the.
Okay, no worries. Vancouver is for hip. And okay, regarding the treatment, you've done the workup, and
Yes.
how will you proceed that?
Sir, on the basis of the emergency treatment with the back slab, and then with the on the management of the periprosthetic fracture, I will like to do the implant fixation with open reduction internal fixation. If there is no implant loosening, and if there is implant loosening on the femoral part, then I will have to do the change of implant and with the
So there is no
step
loosening.
prosthesis.
In
If
the
there is
first
no
scenario,
loosening,
there's no loosening. You
if
have
there is no
got the
loosening,
CT
then
scan.
yes, sir. If
Yeah,
there is no loosening,
you got,
then
got
after
the CT, there's no problem.
the all the radiological workup with X-rays and CT scan, for the fracture management, I will go with the open reduction internal fixation with the plate fixation, sir.
Okay. And what other options you have? Irfan, can you go to the
Sir,
previous picture? I think
Sorry.
we have changed.
Time's
sir,
up
other
actually.
So
The time's up.
other than, okay, any other option other than the plating?
sir, stem implant.
Okay, before stemmed implant, anything? Okay. Is the time up, Irfan?
Yeah, please.
Okay. Okay, we'll start with the next one, please. Yeah. So what can you see? And it's a fracture. Yeah. So the plan is for open reduction for this case. So as
Okay,
you can
sir.
see the question over there. So
Yes, sir.
will you please describe me the technique of the lag screw?
Okay, sir. Sir, lag screw should be applied perpendicular to the fracture, with the
Yeah.
over drilling on the superior cortex and to the inferior one, and applying the lag screw with the 90-degree on the fracture side.
Okay. So in this fracture,
Yes.
which lag screw, which size lag screw you'll use, which drill is, and will you use?
Sorry, sir.
Which lag screw for use for if you are fixing the fibula, which size screw will you use?
Sir, 3.5 mm, sir.
Yeah, okay. So what are the different steps of the lag screw like? How do you start? And you told it's a perpendicular and over
Yes, sir.
drilling.
Yes,
And
sir.
what are the next after this over drilling? Any else?
Sir,
Anything else you need to do?
yes, sir. After over drilling to the proximal cortex, sir, we have to clamp the fracture and reduce it, and then applying the lag screw to perpendicular to the fracture side after reduction, sir.
Okay. Anything else to increase the surface area of the screw head for the smooth transfer of the stresses? Okay. Okay, that's fine. And if we coming to the next thing, if you what type of plating can you do on the medial side? What do you think? What will be the mode of plate if we apply on the medial side?
Sir, mode of plate would be as it is a vertical medial malleolus fracture. So it should be done with the submuscular plating, or sir, the plate should be and the screw should be perpendicular to the fracture side.
Submuscular plating is about the
So
approach
it should,
or the planes. Like what are the different modes of plating you are aware of?
sir, the different modes of plating are bridging of the plate, compression
Yeah,
mode of plating.
yeah. And anything else specifically for this fracture?
Sir,
Any buttress or
gliding and
anti-glide?
anti-glide of plate.
Yeah, anti-glide. Okay, so how do you apply the anti-glide plate? And you know the principle, how do we put it?
Sorry, sir, I can't hear you, sir.
What's the
Sorry, sir,
principle
the voice
and
is
how do we
interrupting.
put the anti-glide plate? Can you hear me?
What will be the principle of anti-glide plate over here when you are applying?
Sir, after if the principle of anti-glide plate is the screw should be perpendicular to the fracture pattern. This is the fracture of the verticals in vertical pattern, though the anti-glide
Where,
screw
sorry
should be.
to interrupt you. Where do we put the first screw in the anti-glide plate?
These are the numbers. Which screw will you
Yes,
put first?
sir, the first screw should be on the third one as the to reduce the fracture vertically.
Time's up, Heather. I know you have to go. Can you please give Adnan feedbacks?
Yeah, if you can come to the first case.
All right. You can start from here, as sorry, I have drawn it, so that's why.
Okay, yeah, okay. So the anti-glide, we start with the shoulder of the fracture, where the Irfan is drying. So the first screw will be here, where the Irfan is dry to be drying. We can't put first screw in the fracture, and it's usually the under contoured plate. The anti-glide or the buttress mode is just to support the fracture, and like we put in the volar bottom fracture or in the medial tibial plate to fracture over here as well. So it's a uh, it's a glide like anti-glide plate which protect the fracture from gliding down. And after this, we can fill the distal screws as well, but we take start from this shoulder. And regarding the leg screws, yeah, you should be aware of the different sizes. Like if we are using 4.5 screw, and what will be the size of the over drilling? Like we have to over drill about the same size of the screw. If you are using the 4.5 screw, then the proximal cortex we will over drill by 4.5, so that screw passes through very smoothly over there. And the last step of the leg screw is the countersink. We countersink the screw. It helps to transfer the uniform stresses, and it prevents from the fracture as well of the ipsilateral cortex. And I think you lost a bit a flow with it. And the different bridges of the modes of the plate are like the bridging plate and the compression plate, neutralization plate, which we put with the leg screw. And the next questions were there, if what are the different indications of the plates, where we put the anti-glide plate, or why we use locking plates, and where we use the bridging plates. I think you will need to go through all of these topics, although they are a bit basics, and we need to revise this year, and this is an important for examination point of view.
So lag screw has been tested in talks in CPSP quite a few times. It should be on your fingertips, the steps, drilling, over drilling, countersink, putting the screw, and perpendicular. And then as Heather has very nicely used his words about the lag screw and why we sink the head of the screw. So if you say these words, the examiner will not hesitate to pass you. So going back to the first case.
Yeah, first case, I think you taken the start very nicely, but the loosening, you said more than X-ray, we can get a CT scan definitely for these complex fractures around the joints. Don't be hesitant to get a CT scan. CT scan will help us to know about the comminution and the loosening. CT scan is definitely better than the X-rays to see the loosening in all three planes. And it's very good you ruled out the infection as well. There is no infection, blood markers, and we can do the alpha defensin test in theater as well by aspirating the joint. And other than that, we can document the retrograde nail as well. Retrograde nail can't be combined with every type of the total knee replacement, but the knee replacements which have a box design, the retrograde nail is a very good option, especially when we can have two distal screws in the retrograde nail. It's definitely better than the plate, and more preferred treatment, and less invasive as well. And the other treatment, we can combine it with the plate as well, which is called nail and plate construct, which is the most stable and stiff construct to help with it. So we need to know about all the treatment options. In the beginning of the Viva, you can tell all the options, and so that the examiner can have an idea that you know about all the things and you have seen. And then you can start to explain your preferred one. And yeah, that is an option, the long stem. Here, it will be the like distal femur replacement. And with a long stem, that will be the last option after all these three options if they are not working. And yeah, so there was a bit issue with the flow, but I think they are not very common cases over there. So maybe you haven't practiced much on them, but I think with the increasing trend of the arthroplasty everywhere, you need to be aware of the periprosthetic fractures.
Thank you, Heather. And Heather, if you go to the meeting and come back, if we are still going on, then please join. And thank you so much. Adnan, I will just add that it's all about principles first and then management, as Heather said. So you should give an impression to the examiner. This is an AP radiograph with an obvious finding of periprosthetic fracture. To know about loosening, I need more investigation. There is a question in the comment that there is no metal subtraction CT. I understand we don't have that, but still we need CT. It will give us some idea. And if the examiner says this, that we don't have metal subtraction CT, then you say, I will keep on my backup all these options. And as Heather has rightly said, there is an option of nail plate combination, and then comes the distal femur replacement arthroplasty with a modular stem. So you should give an impression to the examiner that you know the principles, you know the options, and then we can go ahead. So the next candidate, sorry, I think we need to do the short cases for you. Adnan, are you still here? Adnan, are you still here for the short case?
Yes, sir.
Are you okay to go for the short case?
Yes, sir.
All right. So this is a short case, and Heather and my long case was in CPSP exam. So this is a 15-year-old patient presented to you in clinic with these deformities. And just go like in CPSP, you ask 2 questions and then you go for examination. So how will you proceed? 15-year-old patient in clinic.
Sir, first of all, I would like to introduce myself, and then I would like to ask 2 questions. Sir, sir, कब से ये मसला इसको हुआ है? क्या ये बचपन से है? और इसके अलावा इसको किसी और जगह पे कोई तकलीफ या मसला होता है?
ये पैदाइशी है, और जब से पैदा हुआ है तब से हमने काफी इलाज कराया, लेकिन ये ऐसे ही है।
ठीक होगी। Sir, I would like to start with my examination with first of all, I would like to see any walking aid, and then, sir, I would like to start with the inspection from the front, and on inspection, there is a scar marks. If to see any scar marks, lateral side callosities are present, inverting deformity of the bilateral feet is present, and I would like to see the gait of the patient, and then from the after analysis of the gait, I would like to see the patient from the side. From the side, I would like to comment on the arches of the foot. On the back, I would like to see any deformity on the heel side, and any scar mark or any callosities present. And then beginning to the next step, I would like to palpate, and I would like to see the range of motion of the joint if there is a supple or a rigid deformity. Then I would like to see the dorsiflexion, all the range of motions of the ankle, and then after feeling this deep tenderness to the all the structures around the ankle and the foot, I would like to proceed to the neurovascular examination, and on to see the sensations, and then with that sensation, and then the power of the muscles around the ankle, or including all the muscles of the foot and ankle joint passing through it, and then to the to rule out the any spine pathology from the back side, and any on the knee hip area.
All right,
And
so you
sir,
have done
then after
examination, and I will just tell you the findings. There are callosities on the lateral aspect. There are multiple scars, and there is the one scar going from the lateral to the back and the medial aspect. There is no problem in the spine. He has good power in all of his muscle, but there is no movement at all, and this is a fixed deformity. What will be your next step?
Sir, as this is a fixed deformity and previously treated from the scar mark like Cincinnati incision, so there would be any, there must be a soft procedure already done. So the bony fixed deformity, so I will plan for the deformity correction. As the patient is 15 years old, I would like to counsel the family regarding the my bony deformity correction procedures, as this is a case of resistant or relapsed CTV.
So I am the family. Counsel me. You can use Urdu, Punjabi,
So,
whatever you want.
यस सर, कि आपके बच्चे की जो पैदाइशी पाँव की टेढ़ेपन की बीमारी है, इसका इलाज आपने मुकम्मल करवाया है, उसके बावजूद इसकी जो सी ये टेढ़ापन है ये ठीक नहीं हो रहा, तो इसके लिए मुझे इसकी हड्डियों की दुरुस्तगी चाहिए होगी, जिसके लिए मुझे इसकी हड्डियों को काट कर सीधा करना होगा, और उसके लिए मुझे आपकी इजाज़त चाहिए।
पर इसको कोई मसला नहीं, हम ये तो चलता फिरता है, भागता है,
अ,
तो
अगर ये
इसको तो कोई
अगर ये इसी तरह ही चलता फिरता रहेगा, जिस तरह आप देख रहे हैं कि इसके पाँव अंदर की तरफ मुड़े हुए हैं, तो इन फ्यूचर कुछ सालों में इसका पाँव के जोड़ खराब हो सकते हैं, उसके बाद फिर इसके सीधेपन का उतना फायदा नहीं हो सकेगा, और हमें इसके जोड़ को मुकम्मल तौर पर जाम करना होगा।
ने तो इसका इलाज कराया है, और हमारा ख्याल है कि ये ऐसे ही चल पड़ेगा, तो हम नहीं अभी इलाज करवाना चाहते।
अ, ठीक। तो सर, एज द फैमिली इज रेजिस्टेंट टू प्रोसीड फॉर एनी बोनी प्रोसीजर्स ऑफ CTV।
That's great. So yeah, we will proceed to the next. I'll come back to the feedback after that. This is a 50-year-old patient presented with unilateral knee pain of the left side. Can you see the picture and describe me and do the examination?
Yes sir, on the picture I am seeing the healthy old male with the geno venom deformity on the left knee, although the right knee is typically fine, while the on the left knee there is a patella facing laterally, and the various deformity of the knee is obvious with the wasting of the calf muscles. And sir, now I
Yeah,
would like
examine
to.
now.
Yes, sir. I would like to examine the patient, starting from the inspection. As the deformity is visible around the knee joint, I would like to see any scar mark, any stria bruise, or any infective signs on around the knee joint. Or I would like to ask regarding the history about two questions: if there is any trauma, or is there any redness or swelling to the patient.
So no trauma, no scar mark, and he developed this over the last 5 years. And you have seen from front side back. Now move to the next
Yes, sir.
step from
I
inspection.
would like to do the calf on examination. There is a calf muscle atrophy seen in the left side. I would like to see from the side to the popliteal area from the back
So
side any wasting stria.
inspection is completed. What after
Okay.
inspection?
Yes, sir. On palpation, I would like to first, and then next I would proceed for the gait of the patient, to I ask them to sit on his toes, squatting, and then stand on his toes.
Right.
After
So
the gait
he
analysis
is
of the
able to
patient.
do this, and he has a barrel thrust on the gate. What next?
Yes, sir. On superficial palpation, I would like to see the temperature, tenderness, and then on the deep palpation, on the bony landmarks, I have to rule out some of the bony pathologies
So
around the
there is
joint.
tenderness on the medial aspect. Other than that, no finding in palpation. What next?
Yes, sir. Then I will like to do the sir movements around the knee joint to
So
see
he
the all
has
the
the 10 degree to 100 degrees range of motion. What next?
yes. Sir, then I would like to see the to measure his calf muscle growth, power
That's
of the muscle.
normal.
Yes,
That's
sir. Power
normal.
of the
What
muscle,
next?
normal sensations around on
Power
the
is
low.
fine. Sensation is fine. What next?
Sir, I would like to see the neurovascular involvement and the distal pulses
That's
and
fine.
sensation and reflexes.
That's
Then I
fine.
would
What
like to
next?
move towards the sir. I would like to do the investigations of the patient.
Okay, what do you need in
Sir,
investigation?
I will need sir X-ray on of the knee
Describe this
joint.
X-rays.
Sir, there is a symmetrical narrowing. Sorry, sir, there is a asymmetrical narrowing with the bilateral medial joint space narrowing with
Okay.
the yes, sir.
So you have seen this X-ray. That's fine. Any other investigation you want?
After sir this, I would like to do the hematological workup.
That's fine. Any other investigation?
Uh, so that's fine.
Okay, you patient is going for knee replacement. Anything you want to
Yes,
do before
sir.
it?
Yes, sir. If the patient wants a treatment, and then I would like to do the infective workup.
That's fine. Anything else?
Sir, whole limb X-rays from the
All
femur
right.
to the
So this is the X-ray. Can you define these lines? What is this
yes,
line?
sir. Yes, sir. This is the line from the femoral head to the toe with the anatomical axis, mechanical axis of the limb.
Okay, yeah, go on.
Yes, sir.
So can you tell me
I,
about what are these angles?
sir, this is the mechanical axis of the femur with the anatomical axis of on the tibia.
What is this angle and this angle? All right, time's up. So let's start with the feedback. Well done. I'll start with the feedback of this case. So this is, I think you started very well for the knee valgus knee examination. Sorry, I think we will run out of time and we'll start the next meeting. I'm very sorry for all this chaos. So I am going to share the next link and then we will start there. Sorry for that.
Yes, okay, sir.